Hi, this is Elliot Fishman, and welcome to part 3, and that's 3 of 3 on chromophobe renal cell carcinomas, what you need to know. Let's finish part 3 by looking at some classic and some not-so-classic cases. Remember, we spoke about calcification. Here's some calcification on non-contrast CT, large mass. The lesion enhances. You can see there's some apparent vascularity in the lesion. There's a central scar. You can see that there is some prominent vascularity and stretching of vessels. When I see that, I'm always thinking about clear cell renal cell carcinoma. And in fact, the vascularity around the edge of the lesion to me is very worrisome. And while I might have thought about a chromophobe on the non-contrast with the calcification, when I start seeing the peripheral enhancement here, look at that neovascularity. This to me is not going to be a chromophobe renal cell carcinoma. To me, this is going to be a clear cell renal cell carcinoma, maybe a sarcomatoid variation with this extensive neovascularity. It's not going to be those unusual tumors like MEST tumors, MEST. It's not going to be a papillary. Look at the aggressiveness, size, the vascularity, and the calcification. So you can see the tumor does not grow into the renal vein. There was no adenopathy present, but the vascularity is indeed impressive. And here it is on some of the late venous phase imaging with that central scar. So maybe this is a chromophobe because of the central scar. But remember, many tumors can have central scars. Remember how we spoke about FNH having a central scar? Then we found out that every tumor can have central scars if you have a good enough imagination. So what do? Central scar and calcification, great for chromophobe, but that neovascularity is just not good. And this was resected and it was a chromophobe renal cell carcinoma. So the point is, some of these cases are going to be impossible to diagnose, and they will at times have prominent vascularity. Here's another case, patient with a prior right nephrectomy, solid mass left kidney with calcification. Here, when we give contrast, it's well defined. It's not very vascular. You see, this would be a perfect chromophobe, well defined, solid, not very much enhancement, but calcification. And here, as you go from the arterial to venous phase, the lesion's better defined, but again, a solid lesion, no neovascularity. That was a chromophobe. Another one, large mass left kidney. This could be anything on the non-contrast. Measures, in the 20 Hounsfield unit range, but that could be anything. Now you give IV contrast and there's enhancement present. It's vascular, but not what I would call hypervascular, but it's vascular enough for me to worry that I'm dealing with something more than a chromophobe renal cell carcinoma. It's a very large tumor. You can see the distortion of the remaining normal left kidney. You can see how large this mass is. You can see some prominent vascularity. And to me, I'm pushing to clear cell renal cell carcinoma. There's some AV shunting when you look at the MIP imaging, which is again something you're classically going to see in renal cell carcinoma that's of clear cell variety. So to me, large mass, vascular, this is going to be a clear cell renal cell carcinoma. On later phase, it does wash out, but still has vascularity. Here is on the delayed with the calyces being distorted a bit. That's simply because of mass effect. But this was what was called an oncocytic chromophobe adenoma, which is a chromophobe renal cell carcinoma, just some fancy variant. But again, size is good because we said big masses, but size is good for RCC clear cell. But the vascularity to me would not allow me to make a diagnosis of a chromophobe, but this patient was lucky. Again, just a very nice example. Another case, look at this large mass of the left kidney pushing a little bit of the normal kidney forward and across the midline. Again, this could be anything, but it has coarse calcifications. That again pushes you and makes you think about perhaps a chromophobe. There's some vascularity around the edge of the lesion. There's central necrosis. Now, of course, central necrosis is common in all cell types. When tumors get large enough, you lose the vascularity centrally, so the appearance of necrosis is not all that helpful, but the coarse calcifications may be helpful. Large lesion, again, chromophobe can be large, but you're still worried about a clear cell. This was a sarcomatoid chromophobe. Now, pathologists always come up with new modifications. Now, when I look it up, and what does a sarcomatoid chromophobe mean? It's still a chromophobe, but potentially more aggressive. To me, this is an aggressive neoplasm. This was resected. Believe it or not, the nodes were resected. The mass had clear margins. So again, one of the nice things about chromophobe, but the sarcomatoid variant, which is rare. I think this is one of the few cases I have. Those patients will do worse. But again, that coarse calcification pushes you to the chromophobe. Now, in this article we wrote, we made the point about the vascularity. We made the point about the central scar. We made the point about the calcification. But again, we did make the point that this can be indeed very, very challenging. A few more cases. Mass right kidney could be anything on the non-contrast. It's a big mass. And there also is now, as you'll get more images, masses in both kidneys that are large. Could even be lymphoma, right? Lymphoma involving both kidneys. They look like some right paraortic nodes. Here's with contrast, that's a hemangioma in the caudate lobe. Large masses, there's some vascularity near the edges of the tumor, right? You can see it here as well. You can see the extent, very impressive tumors. Here I'm thinking about clear cell renal cell carcinoma bilateral. I'm even thinking about metastasis, and I'm also noticing the left renal vein is involved with tumor going up into the IVC. So to me, yes, I know chromophobes can involve vessels, but they typically don't. They're typically resectable. When I see involvement, I think about renal cell carcinoma. I even think about transitional cell carcinoma. Now, when I say renal cell, I meant clear cell. I think about transitional cell carcinoma, but this is not a case of transitional cell carcinoma with these large bilateral masses. And it looks like the renal vein bilaterally is involved by tumor, an extensive tumor tracking upward into the patient's IVC right there. And really impressive. And this was biopsied, and again, this was sarcomatoid chromophobe tumor. So I mentioned I had a couple of cases. It's a variant. I'm not sure why you just don't call it a renal cell carcinoma clear cell type or a sarcomatoid tumor, but it's the sarcomatoid variant of a chromophobe, but these are more aggressive. And as you can see, we typically don't think about chromophobes in the classic sense of involving the renal vein or involving the IVC. Now, this was an unusual case with flank pain. There's spontaneous bleeding in the mass. Now, spontaneous bleed, if you disregard trauma or anticoagulant therapy, can be underlying tumor, most commonly a clear cell. Here you can see a mass with a lot of blood present. And when you give IV contrast, the mass enhances somewhat. You can see the areas of cystic change where there's blood. You can see the solid components. When you look at the solid components, they're not very vascular, but I typically would not think about a chromophobe with spontaneous bleeding. This may be the only case I have. This patient did not have trauma, did not have a biopsy. This looks worrisome. When I see bleeding in a tumor, I'm thinking about primary clear cell. I'm thinking also occasionally about metastatic like melanoma, which can bleed. But this solid mass, there's no adenopathy, there's no tumor spread elsewhere. The contralateral kidney looks good. I don't see really anything else going on. but I would have gone with a clear cell. You can see the lesion again on the excretory phase imaging. Still going to be worrisome. This was resected. Surgical margins were negative. They were able to resect it without it bleeding into the peritoneal cavity. They were indeed very careful. They did this laparoscopically, but they were really careful. Here's the same case, the solid component of the tumor on the cinematic rendering, the cystic components, and this was a chromophobe renal cell carcinoma. Again, I mentioned in part 3 we were going to show some of the more challenging cases. Part 1, part 2, you say, oh, I got it down to a science. A mass with calcification, not very vascular, homogeneous, maybe a central scar. Now you're showing me aggressive tumors that bleed, that involve the IVC, that involve the renal vein, and they're clear cell renal cell carcinomas. So there is a spectrum, and as I mentioned, some of the more aggressive have this sarcomatoid variation. So I've gone through a lot of chromophobe renal cell carcinoma. I know a lot of you ask us to be very specific, to give details, and just don't say, hey, let's talk about renal cell carcinoma. We know a lot, but can you give us more information? So what I'm trying to do is we're designing new talks that are more focused, parts of things where we can learn really good pearls in order to be able to better diagnose and manage our patients. So again, chromophobe is the 5%, the third most common lesion. Classically, peak enhancement under 80, washes out on late phase imaging. Again, but it could be a challenging tumor. I started off with showing you this article from JAMA from a few months ago. It's a really good article reviewing renal cell carcinoma, particularly in terms of diagnosis, but also management, and I think it's well worth your time to read. And with that, I wish you a great day. See you later. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.